Okay, everybody. This video is about iliacus and psoas major, otherwise known as iliopsoas. So let's begin, shall we? Page 332 in your textbook. Here we go. Oh, that's not right. There we go. Okay, so here we go. Iliopsoas is a combination of psoas major and iliacus, and I will explain that in a minute. Right here on the anterior hip is iliacus, and right here, this large one right there, that is psoas major. Interesting fun fact about iliacus, that is the filet mignon, or the tenderloin. This is actually the same muscle on a cow or pig that meat eaters enjoy so much, I guess, because it is tasty. Just in case you wanted to know that today, there's your fun fact. So iliopsoas is a combination of these two muscles, and here is where they come together. Okay, so they have different origins, but they have the same insertion. So let's take a look at that. Let's get this up just a little bit bigger. Psoas major actually originates on the bodies of and transverse processes of the lumbar vertebrae. So if we go over here, these right here are the transverse processes. They stick out from the sides of each vertebrae. We've already kind of talked about spinous processes a little bit when we were talking about the sacrum, because spinous processes jut posteriorly. Transverse processes jut out from either side of the spine. So the body of the vertebrae is just a thick bit in the middle, and the transverse processes are these right here. So the origin is the bodies and the transverse processes of the lumbar vertebrae, and there are 5 of them. So you can see 1, 2, 3, 4, 5. That's not necessary to know, other than when you're talking about the bodies of, you're talking about all of them, and there are 5. The insertion then is the lesser trochanter of the femur. So what happens is, pardon me, psoas major comes down like this to meet iliacus, and then it dips back all the way to the posterior aspect of the femur to attach to the lesser trochanter of the femur. That is really going to have a lot to do with the actions of these muscles, okay? All right, so let's go to iliacus then. So iliacus originates in the entire iliac fossa. Okay, this whole thing is iliacus. Then, of course, it does the same thing, and it comes down like this and then dips back to the lesser trochanter of the femur. Now, some people, about 40% of the population, have a psoas minor, which is this little one right here. But psoas minor is a minor player, ha, pun intended. It doesn't do a whole lot. And you don't know if you have it or not. So it's sort of irrelevant right now. Psoas major and iliacus are really what we want to talk about here today. Let's talk about the actions. This may get a little confusing, and I will try to clarify. What you see here is it says with the origin fixed. Now, what that really means is the insertion is going to move towards the origin. So a traditional action. Insertion moves towards the origin. So what we have with the origin fixed, and these are pretty much the same, is flexion of the hip. Flexion of the hip is the main action of iliopsoas. These are powerful hip flexors, okay? Which makes sense because you are moving the insertion closer to the origin. So the lesser trochanter gets pulled towards the anterior and the whole hip goes into flexion. Okay, perfect. Now, also because we are attaching to the lesser trochanter here, if we pull this towards the front of the body, what tends to happen is the femur itself gets laterally rotated as the lesser trochanter moves towards the front of the body. So that is another action of iliopsoas, is that it may laterally rotate the hip. It doesn't have to, but it can, okay? And again, that's a traditional action. So the origin is what we said it is, the insertion is what we said it is, and the insertion is moving towards the origin. Everyone with me so far? Good. All right, now, the other actions with the insertion fixed. Okay, so this is basically where we switch the origin and the insertion. So now what we're really saying is that the lesser trochanter is the origin, and then the iliac fossa or the bodies of the vertebrae are the insertion. Okay, so we're just switching everything around. And if that's the case, then we are moving in the opposite direction. So now the actions are going that direction. Okay, the muscles are contracting in that direction. So in this case, we have actions that include flexion of the trunk towards the thigh and tilting the pelvis anteriorly. So I'm going to stand up and show you these. All right. Oops. Well, and I'll address the unilateral action of psoas in a second. So I'm going to stop the share and explain to you how this works. Okay, so I'm going to stand like this, and you see the seam of my pants here. Okay. Make sure that my jeans are in the right place so that I can show you. All right, so normally, if the insertion is moving towards the origin, we get hip flexion, right? That's the main action of iliopsoas, hip flexion. Okay, that's easy, right? But if we fix the insertion, so we're fixing the spot at the lesser trochanter, then we get two distinct things happening. One, we can actually flex the trunk at the hip. See that? So now what used to be the origin is moving towards the insertion, like that. I'm trying to use my fingers to show you how that would contract. Okay. But you have another one in here that is actually more important, because this one can cause dysfunction in the hip. So what happens, again, see the seam, if the origin moves towards the insertion is anterior tilt of the pelvis. So the ASIS right here, okay, I'm banging on it so that you can hear it. It's right in the little pocket here. The ASIS is actually going to move towards the floor. So watch my fingers, okay? And you can watch the seam too. You see where that went? So I'll put my pelvis back where it's supposed to be. Now, anterior tilt of the pelvis goes like this. Okay. Now, iliopsoas is contracted here. And what it's doing is it's putting this whole pelvis into an anterior tilt, which brings the ASIS a little closer to the floor. Okay. That anterior tilt causes problems for the whole pelvic structure. Okay. When you have the anterior tilt of the pelvis, what has a tendency to happen then is everything in the back that was holding that pelvis in place then starts to become lengthened. So you have shortened muscles in the front, i.e. iliopsoas, and then you have lengthened muscles in the back, like the gluteals, okay? So it creates a pattern of muscular imbalance that you as a therapist are going to learn to recognize and then work with and address. Okay, so put that maybe aside for now. We will talk more about these patterns of muscular imbalance specifically in your pain, gait, and range of motion class. Let's go back into the screen share for a second. All right. So one more action for psoas can assist to laterally flex the lumbar spine. So lateral flexion looks like this. The whole spine goes to one side laterally or the other. It is not a strong lateral flexor of the spine at all. You have a lot of other muscles that do that. That's why it says assist to laterally flex the spine. And again, if we're talking unilaterally, remember we go back to our unilateral versus bilateral discussion from the traps, right? When one side contracts at a time, it is a unilateral contraction. If both sides contract at the same time, it's bilateral contraction. So we're just talking about one side of psoas contracting at a time, producing lateral flexion of the lumbar spine. So let's take a look at these because I think it's really important to see where these go. So from an anterior view, this is what it looks like. Here's psoas major, this little guy is psoas minor, iliacus, of course, and this structure right here is the, yes, indeed, it's the inguinal ligament. Okay, good. Let's turn this to the side. This is what I want you to see. Okay, so you see, because it's highlighted now, how iliopsoas wraps down around the pelvis and then back to the lesser trochanter of the femur. Remember, the lesser trochanter is posterior. So if these muscles are producing, if the origin is fixed, then the greater trochanter is going to move up into hip flexion. If the insertion is fixed, then this is where we get the anterior tilt of the pelvis. And unfortunately, I can't show you that action right here, but you can see how this would pull the whole thing down towards the femur in that direction, pull the whole coxal bone down towards the femur. Okay. All right, so that's iliopsoas. That's a nice view of it too. Okay, you can see how it wraps itself down around. Now, the other thing I want to mention about iliopsoas is that it is palpable. In other words, we're going to be able to palpate iliacus, but not so much psoas. And the reason is because this whole area is filled with viscera. In other words, your guts, your intestines, mostly. We can palpate in the iliac fossa though, so we will be able to palpate iliacus. But we're going to have to be very careful when we do that because we don't want to be poking guts. We don't want to be poking at the intestines, okay? All right, so this is what they look like individually. Iliacus is quite a bit larger than psoas major, as you can see, but they go in the same direction, okay? All right, so when do you use your iliopsoas? Well, any time that you are flexing your hip, you're using iliopsoas, okay? So sitting, lifting your knees, you're using iliopsoas, and you can actually palpate in your hip area. Lift your knees while you're sitting here, and you can feel iliopsoas contract in the iliac fossa. And basically where you're going is where your pocket is in your jeans, okay? or if you're not wearing pants with pockets, you can access your ASIS and then, slide your fingers into the iliac fossa. Okay, or I just kicked the table with my knee. Oops. All right. That is it for iliopsoas. Have a nice day.